I guess I'm going to start off. I'm Linda Wilhelm, and I just want to welcome you all today. I'm a person with lived experience of chronic pain. In 1983, I was diagnosed with rheumatoid arthritis. I have a particularly severe aggressive form of the disease and have had many, many surgeries. And now I'm doing well, but trying to improve the world and for other people living with chronic pain. Next slide. I have no conflict of interest or disclosures. So for many years, people living with chronic pain, their healthcare providers, researchers, and other non-government organizations like Pain BC have been contributing to a movement to try to get some action on the management of chronic pain in Canada. We know there's innovative clinical models that are improving approaches. There's great research happening all over the country in pockets, but still we need some national policy. We need to get those great models so we can move them across the country and expand them, accelerate the work and try to make things better for people living with chronic pain. The collective work has people were doing, next slide. The collective work that everybody's been working on for so long led to the creation of the Canadian Pain Task Force in 2019. This was a formal commitment by the federal government to try to better understand the needs of people living with chronic pain in Canada. Next slide. So the task force and the expert advisory panel is made up of 8 members for the task force of people with lived experience, Indigenous perspective, researchers, educators, healthcare professionals, all with experience and expertise in the prevention and managing of chronic pain. We're also supported by an external advisory panel that gives us up-to-date scientific evidence, information, and advice on representation from across the country with great broad experience on the issues of chronic pain. The work is well supported by the Secretariat at Health Canada, and you'll hear from Andrew in a few minutes, and also engages with the federal, provincial, and territorial working group to try to expand the work and the knowledge that we've been doing for the last year and a half, and hopefully will continue to do in the next year. Next slide. The task force has a 3-year mandate. It's quite broad to collaborate with the provincial, federal, territorial governments, professional association, and people living with pain to assess how chronic pain is currently addressed in Canada, to conduct national consultations and review available evidence that identify best and leading practices and potential areas for improvement and elements of an improved approach. And that was the focus of our second report. Assessing how chronic pain is managed was the first report that we published in June of 2019. We just published our second report last month. I'm sure many of you have seen it. And now we're going to be working on phase 3 to get the information out and try to expand the models and best practices across the country and facilitate their uptake. Next slide. So phase 1, with the assessment of the current state of chronic pain, we did a consultation with the federal, provincial, territorial government representatives and pain stakeholders and reviewed the published evidence. So no surprise to any of you that chronic pain is a significant public health issue and in need of dedicated actions. Also, people like me who live with pain lack the information, management strategies, and we encounter stigma and difficulty getting our treatments. And also, we also know that the emphasis on the harms of opioids and the opioid crisis have resulted in stigma and harms for people living with pain and leading them to be at risk for illicit stuff, at risk of overdose. Healthcare professionals are not adequately trained to assess and diagnose and treat pain, and people living with pain are well aware of this. Next slide. So the health system is not effectively managing pain. The system does not support the biopsychosocial model for multimodal care, multidisciplinary care. The wait times for the specialized clinics in Canada is 6 months. Often, where I live in New Brunswick, it's 2 years, 4 years. And not even, and I've heard of people not even being told what the wait time is because it's so long. Limited pharmacological treatments are often the only pain treatment available. And this has happened a lot with COVID-19 as well, when many patients now are relying on virtual care and not able to access the clinics and the treatments that they use to help manage their pain. Multidisciplinary interprofessional clinical models, education approaches, provincial policies, world-renowned research, they all exist here in Canada across the country, but they're just in pockets, and we need to find a way to move those to access, so everybody will be able to access them. And we need leadership and resources to coordinate, amplify, spread, and accelerate the work. Next slide. So this leads us to phase 2, which was our stakeholder engagement process. And I know that many of you participated in this process, and we had workshops across the country in all our various regions. We had Indigenous talking circles. We would like to have had another one, but COVID-19 interrupted that partway through our consultation. We had tremendous online consultation, people providing input, people with lived experience, and this took place throughout July to August of this year. Next slide. So engaging the Indigenous people, there was a talking circle in Winnipeg, Manitoba. A second one was scheduled for Nova Scotia that had to be canceled because of COVID-19 restrictions. So this was to better understand the Indigenous people's experiences of chronic pain and discuss potential ways to improve the prevention and management of pain for First Nations people. It was primarily attended by people in Manitoba and Saskatchewan. And was in collaboration with the elders, knowledge keepers, and representation from Natives Women's Association of Canada, Assembly of First Nations, Thunderbird Partnership Foundation, Indigenous Services Canada, and to ensure that the input was gathered in a way that was compassionate, socially and culturally informed and inclusive. Indigenous peoples also submitted through the online questionnaire, written submissions, and other regional workshops. Next slide. So phase 2 is working together to better understand, prevent, and manage chronic pain. And this is what we heard. There was a strong consensus around best practices and strategies for action, which required, as I said, leadership, coordinations, and resources to accelerate already working. The findings divided across 5 areas, which was access to timely and patient-centered care, awareness, education, and specialized training for pain. Next slide. Pain research and related infrastructure, monitoring population health and health system quality, and Indigenous peoples. Next slide. So reflecting on inequality and disadvantage and trauma, this was something that really came out across the time of our consultations on racial inequalities and the access to healthcare that disadvantaged people, and that chronic pain is very unevenly distributed among Canadians. Occurrence, severity, barriers to care are higher in populations affected by social inequities, discrimination, and these groups are often, almost always, affected more by multiple forms of trauma. And trauma and violence-informed care also came out in this report. Practitioners take into account the patient's experience, preferences, and history of trauma, including adverse childhood events, and need to create an environment of trustworthiness and safety. And there's some quotes from our people that responded. Next slide. So reflecting on the impact of COVID-19, which I briefly mentioned, that the community resources and exercise facilities that many people with chronic pain use to help manage their pain were closed for months. and some are still ongoing, being closed. Reduced access to physiotherapy, rehabilitation programs, and psychological services. The in-person peer support programs were canceled, and then everything went to telehealth, phone lines, and video care. Decreased specialty pain clinic services, patients grappling with the increased use of medication and other substances, and drug shortages propelled by COVID-19 were creating barriers for accessing medication. And then triggered pain goes unmanaged and gets exacerbated. Then we've got to also look at in the future chronic pain following the viral infection like COVID-19 that with the long haulers that could go on to develop chronic pain. Next slide. And I'm going to turn that over to Andrew, and he's going to talk about some of the successes we've had with the government, some of the actions that's occurred since the beginning of the task force. Andrew.
Great. Thank you so much, Linda, for the presentation, and also for all the work that you've done on the task force. You've been a tremendous help to us as we're looking to better understand the issues and what we need to do about it. So I'm currently acting as the director for the small team that helps the Secretariat. We're in the Controlled Substances and Cannabis branch at Health Canada, and not only do we help the task force, we also work to try to better understand what's going on in different provinces and territories, as well as other departments in the Government of Canada. So I'll talk a little bit about some of the things that we're doing, but also where we're thinking of going a bit. So next slide, please. The federal government does have a role to play in supporting the health system, but the provinces and territories are really the ones that have the primary responsibility over the delivery of healthcare in Canada. So during our first two phases, it was really important for us to connect with all of our provincial counterparts to see what actions are taking place, what supports might be needed. It was this consultation work that led to an informal working group on pain that we currently have now that has representation from all jurisdictions. And we try to meet regularly along with the task force to better understand what's happening. So through this experience and through the working group, we understand that provinces and territories are doing a lot of actions for pain in a lot of common areas. So we know that jurisdictions like Alberta and Newfoundland and others are currently mapping the services that are available within those jurisdictions, identifying best practices, trying to figure out what is available and what's not. We know in other jurisdictions that networks are being created, such as in Ontario and Saskatchewan, where networks of patients and clinicians and others involved in pain are coming together to better understand and explore future next steps. We also know that some provinces are developing strategies. So BC is a great example of a collaboration where many people have come together to create a vision for how pain could be transformed within the province. There's also an implementation plan about what could be done. We know Alberta and Nova Scotia are also considering similar types of strategies. We know that lots of jurisdictions are looking to explore potential pain care pathways and guidelines. Many are exploring more centralized approaches to the assessment of pain and to figuring out care delivery. Many are also producing guidelines and quality standards to help clinicians better manage people that present with these kinds of challenges. We know that many provinces are building capacity within primary care to support pain, and some are even investing in improving access to multidisciplinary clinics and care. We know from Linda's discussion that wait times are a huge issue, and it's large in part because there just aren't a lot of services available in many places. And so jurisdictions like Ontario are investing in these types of clinics and trying to build up that capacity. We know a lot of provinces are also trying to build up self-management related supports. Pain BC is a great example of a resource for self-management, but lots of other ministries and provinces have chronic disease management programs, and both in person and online trying to help people with the management of their needs. And we know that many jurisdictions are also looking to develop education for people living with pain, their families, health professionals, and really expanding and coordinating the research that's happening. So in places like BC, Alberta, Quebec, we're seeing the establishment of provincial pain research networks to better coordinate the kinds of studies that are happening across different disciplines and across different institutions to have a more coordinated approach to prioritizing research and moving that forward. But we also know our provincial and territorial colleagues and many stakeholders across Canada have just noted that the resources are scarce for this kind of work. And even where there is a willingness, there's definitely a call for more leadership, coordination, and resources. So next slide, please. So with that in mind, the federal government has been trying to move forward in a number of ways, and we still have a ways to go, but I'll go through some of the ones that we've been able to do over the last little bit. And one is the ongoing support for the Canadian Pain Task Force. We know that the task force provides advice to us, Health Canada, but they've also, over their tenure, sort of worked to support various pain-related guidance activities and work as well. The task force worked with the Federation of Medical Regulatory Authorities of Canada to inform their revised framework for prescribing opioids and the guidance that's provided to physicians and other prescribers that prescribe opioids. The task force has also worked with the Canadian Agency for Drugs and Technologies in Health to help inform some of the evidence gathering, scanning, and communication tools that they've put forward related to pain-related interventions and models of care, trying to create resources for patients and clinicians to better understand the options that are available for pain. And then, as I mentioned, my group sort of chairs a federal interdepartmental working group on chronic pain. So we bring together the Canadian Institutes for Health Research, the Public Health Agency, Indigenous Services Canada, the Veterans Affairs, Canadian Armed Forces, StatsCan, a couple of other groups as well, just to better understand the scope of actions that are taking place across departments outside of health, because we know that that pain is an issue that touches well beyond the boundaries of the health system. My department is also funding initiatives related to improving opioid prescribing and pain management through our substance use and addictions program. So Health Canada has announced over $14.5 million in funding through this program to support projects which aim to improve pain-related education, training, information resources for providers and medical students and people living with pain. Projects have ranged from establishing peer mentorship networks to online self-learning modules, supporting interprofessional education and pain management, and just better understanding clinical care pathways and guidelines to support people in that journey. One such example is providing almost $2 million to the Association of Faculties of Medicine of Canada to develop a curriculum for all future physicians in the diagnosis, treatment, and management of pain. And we know that they're now well into their piloting stage. And we also provided close to $1 million to national associations for nursing, pharmacy, and social work to develop interprofessional education programming as well. Through the Public Health Agency of Canada, we're supporting surveillance and epidemiological research to better understand the links between the drug overdose crisis, prescription opioids, and pain, and also rare diseases and pain-related disorders more generally. There was some research that was released that looking at the prevalence and risk factors associated with pediatric complex regional pain syndrome. There are consistently fact sheets and information reported on relevant chronic conditions where pain is a secondary symptom, such as arthritis. And pain is also referenced in the social media work of the Chief Public Health Officer and in her most recent report noting the effects of COVID-19. We also know that StatsCan is collecting various data on mental health, substance use, and also links to pain. They've done surveys and data gathering related to pain and disability, most recently looking at doing crowdsourcing work to better understand the implications of COVID on people who face disability and who are unable to work. And they continue to want to work with us to figure out how to build information on the prevalence of pain in Canada. So next slide, please. The Canadian Institutes for Health Research and the Network's Center of Excellence program is the biggest sort of public health funder of research in the country, and they've provided a range of investments to support individual research projects, but have also supported networks related to chronic pain generally, to mobilizing pain-related research and looking at solutions for pediatric populations, and also a network for myalgic encephalomyelitis. Oh, I always get that wrong. I always think I'm going to say it right, and I never do. But there's apologies for anybody that was offended by that. But there's a network for biomedical research in this, and better building support to understand the quality of life issues related to this condition. We've also made some strategic investments in pain-related research in the context of the drug overdose crisis, cannabis legalization, and the COVID-19 pandemic. And we've been working with several institutes, including the Institute of Musculoskeletal Health and Arthritis, to just better map the pain research and priorities that have occurred so far, and to inform strategic planning for CIHR in the future. Next slide. So Veterans Affairs Canada made a pretty significant investment in supporting a Centre of Excellence on Chronic Pain Research. The centre is meant to improve our understanding of veterans' chronic pain-related realities, and making sure that those realities are reflected in research and care. But they're also helping to pilot innovative therapies and enhanced treatment options, and to complement the work of the Canadian Institute for Military and Veterans Health. And they're doing a lot of work that I think will be relevant for all people across Canada who are living with pain. Correctional Service Canada has developed a guidance for managing and assessing inmates who have chronic non-cancer pain. So lots of work going on to make sure that, that inmates in federal institutions are supported and cared for appropriately. And Indigenous Services Canada is also examining gaps amongst Indigenous peoples who may experience and manage chronic pain differently than other populations. So on the next slide. Yeah, so these are only some of the government actions that are taking place, but there are a range of policy levers or actions that we need to consider moving forward. So I've discussed some of those actions to improve program and service delivery, machinery, creating committees and networks, some of the work to improve knowledge development and research and surveillance, and policy development, so better understanding best practices and putting forward standards and guidelines. But we could also explore a number of other levers that I haven't discussed yet. So legislative and regulatory changes are one. So we know when COVID hit, that Health Canada issued a regulatory exemption for pharmacists, which allowed them to accept verbal prescriptions and to renew prescriptions. And this made it easier for people relying on opioid medications to access those medications during lockdown. These measures have since been extended to September 30th, 2021, and perhaps we should consider making that a more permanent change. We also need to think about how the federal government can better support improved communication around pain. This has been a major theme that's come out of the work of the task force, and there's certainly a major role that the government can play in supporting awareness, building efforts related to pain and other factors that influence it. We know that fiscal measures to support the provinces and organizations and individuals also help to provide and build access to necessary care. But pain also doesn't exist in a vacuum. So there's also lots of federal actions taking place to improve the health system more generally. And we're hoping that these efforts will ultimately benefit people living with pain as well as other populations. So efforts to build capacity for primary care, to improve long-term care and home care, to build more services that are virtual in nature, to support mental health, and to look at disability reform. All of these kinds of actions hopefully will make it easier and to receive needed benefits and care that people need. And we hope to connect to this broad work as well. But ultimately, I think our future as a task force and as a government is to explore all sorts of future actions and to see what might be next. And I think that's what our last phase of the task force will be exploring in more depth. So I think at this point, I'll go to the next slide and turn it over to Maria.
Thanks so much, Andrew and Linda, for taking us through the history. So I think I spend a lot of time talking to folks who live with pain and families of people who live with pain, and also healthcare providers about, what is this work going to actually mean? What's the tangible difference that we're going to see? And I think looking at the last slide that Andrew put up, this is where the rubber hits the road when we look at concrete things that government can do. And Linda and I commiserate a lot as advocates we sort of say we're in it for the long game, because many of these changes, they do take time. I mean, I remember Linda telling me a story about working with other people in her province of New Brunswick to get a publicly funded drug plan for residents of that province where there had not been one before. And that effort was really like a 15-year effort. So I think what we've seen with the task force is really the acceleration of this opportunity to bring some of these, we refer to them as levers, but these things that we can pull, they're things that the federal government often controls, or the provinces and territories control, and those can have a wide population level impact. So that's everything from new types of disability supports for people who live with pain, or regulatory changes to make medications safer or more available. Grants and contributions. Currently, the federal government provides significant amount of funding tied to national strategies that have come through this exact type process that we see with the task force. So, we have a dementia strategy in Canada. We have a national drug strategy. And often these strategies come with significant dollars to implement things on the ground in health settings, but also grassroots kinds of initiatives like peer support and other type of initiatives. So as we shift into the phase 3 of our mandate, those are the types of things that we're certainly hoping for. Next slide, please. So going forward, as Linda mentioned, we submitted our second report to the federal health minister in November. And the plan really had been to go forward collaborating with stakeholders across the country, disseminate this knowledge about these best practices and what we can do to spread them and scale them up, and really facilitate uptake across the country. So we were really expecting to go forward and increase awareness and knowledge, really enable many, many people to act on pain. And really, this is not just government. This is, the federal and provincial and territorial governments, but it's other groups that have a really significant impact on the lives of people with pain. So it's medical regulators, it's insurance companies like the health and disability insurers, it's workers' compensation organizations, it's employers. There's like even the health charity sector, there's significant infrastructure in health charities in Canada, but very little of it is focused on pain. So really the next year was intended to drive change through all of these types of mechanisms. So looking at ongoing engagement of lots of different stakeholders, prioritizing activities that might be taken, and then completing our third report. Next slide, please, Elena. So we initially were given this mandate until the end of 2021 with a plan that the final report was really going to summarize the work that we'd undertaken, outline needed actions, and sort of prioritize the plan for government. What we have seen is that just incredible receptivity and endorsement of the work that we've done to date. When these reports, like our second report, was presented to the minister and works its way up the federal bureaucracy, and we've just seen, frankly, a surprising keenness to move forward and explore other options that would really strengthen this last mandate phase for the task force and also accelerate that. So we're currently in discussion with Health Canada about how to, I don't know, attach rocket boosters to the task force in this next phase, and really focus on a quicker report production that really outlines clearly what government needs to do. So more to come on that, but that's a really exciting development. And I think for people like Linda and I, who have done significant advocacy on lots of different issues, we really see this as a huge opportunity and really hitting that tipping point. So I think we're very excited. Next slide, please. So we're here, we're going to take some questions today. People can certainly reach out to the task force. We love getting your emails, both Linda and I, about the way to formally have your feedback or questions sort of logged by the federal government is through this very, very long email address. So that's the way to get in touch. Our reports are posted on the website. And as we finalize kind of this reshaping of the third phase of the task force mandate, that is going to be published on that website and sent out to all of our stakeholders. So you can reach out through this email address, and if you're interested in updates, just let us know, and we'll communicate that once it's been finalized. So I think yeah, lastly, just acknowledging the task force members. We've been, this is a screen cap of some of our epic Zoom meetings. As you can see, we have 8 task force members. We have an incredible team of Health Canada employees that are supporting our work. So that's everything from bringing people together for meetings and corralling lots of herding cats, but also doing lots of internal work with government as shepherds of this agenda, trying to build awareness and buy-in among their colleagues. So we're very indebted to them. And also this incredible external advisory panel, again, people with lived experience and clinicians, researchers, educators from a whole range of disciplines across the country. So we've been just a terrific team coming together, and hopefully we will really be seeing a significant, tangible, and practical change coming from this effort. So Jen, I think that's the end of our formal presentation. So we're happy to take questions or just hear reflections from people who have attended.
Thanks, Maria. Thanks, Andrew. Thanks, Linda. It was really interesting and so good to hear things are going in a positive direction, particularly with this extra federal momentum at the end that you just talked about. So again, if anyone has questions, you can put them in the Q&A. If that is not working for you, you can also just put them in the chat and I will read them out. So we'll just give people a minute or so. What's going to be, I do have a question just in terms of the next phase of engagement. How do you see that working? How are people going to be, how are people with lived experience going to be involved in this next phase of engagement?
Maybe I'll take that one. And, Jen, I think right now, while we're waiting to really finalize what this next phase is going to be, we're torn between wanting to do, continue to do this broad engagement and also reflecting that what we've heard from people with lived experience is sort of get on with it. And that's, I think so many people have been advocating, mobilizing in their peer networks and local communities, and really wanting to see change happen. I think we've seen through our process over the last 18 months, just an incredible consensus across the country around the kinds of things that need to be done. So the work now is really translating the voices, the stories, the best practices that we heard about, the promising practices, these pockets of excellence, and hearing about the needs and the gaps, and then translating that into actionable next steps. So I think, there will be opportunities for engagement, but I think we've heard so clearly the kinds of issues that need to be addressed, and we've also gotten really great guidance around the kinds of things that need to happen. So we don't want to consult endlessly. I think as questions really emerge, like, oh, what should happen with this or that, we'll be doing some targeted engagement. Lyndon, Andrew, do you want to speak to that?
Yeah, I think I'll just add to that. I know part of the next little while will also be reaching out and continuing with the federal, provincial, and territorial bodies that we've already engaged with, and Canadian Institute of Health Research, the Institute of Musculoskeletal Health and Arthritis. I mean, they have a research ethics board, and they have a patient advisory board that advises them as well on priorities. So I think that's another way we'll be hearing from people with lived experience in a more practical, I guess, way. But I think Maria's right. We've heard a lot, and people are, let's just get on with the solutions. And we've heard a lot of good things that now it's try to get rubber hit the road and get some of these things scaled up and get moving with what needs to be done.
Makes sense.
Yeah, I would echo what others say, but also to just emphasize too that hearing from people with lived experience has been an important part of assembling the task force too. So, Linda, you've heard from her today. We have others on the task force. Maria is a very good advocate and voice as well. And it's these people that are really making our task force that much more meaningful and contributing to its final report as well. So I definitely think that we've heard quite a bit since our inception. We continue to hear quite a bit, and the get on and move with it thing is something that we're very conscious of as well. And of course, we have our incredibly terribly long email address, which you can email anytime, but we monitor and we try to get back to people. And if there are resources or ideas or events that come out, we definitely encourage you to let us know as well. We have a few resources that we've been able to put up on the task force website to help in times of COVID, just to point people to different places that they could go. And we're constantly looking to update that in the future too. I don't know what we'll be doing post task force, but I'd like to think that we're going to be figuring out how to implement what's in their final report. And once we get to that implementation phase, the idea of continuing to engage with people who live with pain and stakeholders across Canada is just going to be absolutely essential as well. So while I don't know what that will look like in the future, I can say that the idea of patient engagement and engaging with people is still going to be extremely important to us moving forward.
Thank you. That's really encouraging. And I know everybody's really anxious for action. I did put the email, the long task force email into the chat if folks want to copy and paste that. We can also include it when we send out a link to this recording, and we can include the also very long URL to the Canadian Pain Task Force website and report. So we'll do that along with your presentation and then along with the recording. So I'm not seeing any questions. I'm not sure if, I'm not seeing any questions. If people have entered them and I'm just not seeing them, maybe you can just put them in the chat, because
Yeah, Jen, I can see the questions.
Can you?
I'm happy to speak to them if.
Yeah, I don't have any access to them, which is really weird. I apologize. Okay, that's good.
So, and maybe I'll just, I can read them out. So Kathleen is asking, are there any surveys that advocates can help fan out to their networks that would help the task force? So Andrew, do you want to maybe take that one?
Yeah, that's a good question. None are sort of coming up to that. I mean, we did a survey as part of our phase 2, and we received quite a few submissions related to that. We also were aware through our task force of several surveys that were going on related to COVID-19 and how it was impacting people living with pain. And we managed to kind of send those out through our networks. I think those research projects are have moved along and are no longer recruiting. Although I could be wrong about one of them. Maria, maybe you could correct me if you know of any. But then in terms of Statistics Canada and some of the work that they're doing, I'm not aware of anything right now. But certainly if I come across anything or hear of something that would be relevant, because we have our task force in place, we use them to help fan out and to send these kinds of pieces of information out to the public. And so I think it would just be a matter of continuing to monitor the kinds of communications that you're getting from Pain BC and other similar networks, because we'll be reaching out if things do pop
up. Great.
Yeah, and so certainly with the Canadian Arthritis Patient Alliance and the Chronic Pain Network community, if there's any opportunities that come out, they'll be distributed through those channels as well.
Great. So there are a couple of questions related to opioid prescribing. So one is about the need to have to go for a physical visit to a physician in order to get an opioid prescription. So Andrew, I'm wondering if you could speak to the changes that we were able to see with the Controlled Drug and Substances Act, which really these changes were intended to facilitate access to opioids for people who needed them. So Andrew, can you speak to that? Because as far as I'm aware, people should not be having to go to see a doctor in person in order to get a prescription.
Yeah, and so I think this is something that there needs to be more education on the exemptions for sure. You know, according to the different acts that are in place, you know, you would have to get your prescription from your doctor, potentially go in person, do the kinds of things that are challenging for people. Last spring when COVID hit, recognizing that we're trying to limit people's exposure and leaving the house, there were some regulatory exemptions put into place where pharmacists would be able to accept verbal prescriptions and to renew prescriptions over the phone. It was supposed to make it easier for people relying on opioids to be able to access those medications. So we know that those measures are in place at the federal level. How it trickles down into the provincial level and to individual clinics and prescribers, we're not entirely sure of. So I can say that those exemptions were put in place as a temporary measure, but they've really been extended until next fall, recognizing the complications that have happened because of COVID, and just recognizing the value in these kinds of exemptions for improving access. So you know, I would encourage you to speak to your healthcare provider about options for renewing prescriptions in a more of a virtual way, and to limit the need to go for in-person appointments and visits. I think it would depend on your individual case and your provider, but those exemptions do exist at the federal level to help make sure that those measures and that flexibility can be put into place.
And we can also distribute the notification that went out about those exemptions, because it is possible that some healthcare providers are not fully aware of the changes that were made in order to protect people who live with pain and who require opioids during the pandemic. So we can get that some information and have it distributed. Sorry, go ahead.
And then I wonder if that's they're talking about a first opioid prescription, like the initiation, but not necessarily a refill, which I'm not sure how that works. But for refills, I live with chronic pain. I take an opioid, and I had a virtual appointment for my refill with my own physician in New Brunswick. So maybe it is about getting more awareness about what the changes have been.
Great. So there is another question about the auditing of physicians for prescribing opioids and whether individual patients are being audited. So we know that while there have been lots of efforts to change sort of the policies governing opioid prescribing. So here in BC, the College of Physicians and Surgeons actually has legal standards around opioid prescribing, and Pain BC was very active in shifting the language of those, along with many other people who were advocating. So now the language is very clear that people who live with pain cannot be discriminated against. People who require opioids for pain management cannot be fired or by their physician or otherwise discriminated against. So I think what we've seen is success in changing the actual language of the policy, but the practice of physicians still being quite focused on deprescribing opioids, the sort of broad weaning of everyone without a really patient-centered approach. I think that practice continues, and we're certainly very concerned about it and continue to raise it with the provincial government, with the college, and with the federal government. So quite a lot of work being done on that front, as well as trying to raise the issue in the media. Linda, did you want to say anything around the issues related to prescribing?
Yeah, I mean, I think we've done a lot of work. The Health Canada reached out to the patients from the Chronic Pain Network for advice around language on the stigma associated with opioid use and prescribing. This pendulum shifted so far in response to the opioid crisis, which, legitimately there were issues, and this was a crisis. People were dying. But it shifted so far that inadvertently patients in chronic pain got caught up in policies that, and I think that it helped to create the pain task force ultimately in an effort to try to bring some balance back, and it takes time. We're getting some of that balance back, but it's certainly just not always going to be done overnight, unfortunately.
There are a few more questions and something posted in the chat around the exemption. So we will get news out about that. We'll make sure it's posted to our website. And folks can always reach out to Pain BC either through social media or the info@Pain BC email address if you can't find something or you have questions, and our team will triage it to the right person. Andrew, there's a question about, will we be putting out updates as things are implemented? And I am just going to turn that one over to you, because once the final phase of the task force is completed, the task force will, in its current form, be disbanded. That's what happens with all federal task forces. So there'll be pieces of work carried forward by the government, and then I think questions around what will sort of the more community or stakeholder-based network, or like what's that going to look like in the next phase? So I think still some questions, but Andrew, can you speak about implementation stage of communications?
Well, I mean, that's a challenging thing to comment on, because it's we still don't know, but we're exploring how to do it, because we recognize that the need is there. So if you're referring to updates related to the task force, you can go right on our website. We've got summaries from all of the meetings of the task force and its external advisory panel. We obviously post our reports on there as well. We've got a section for resources, which admittedly we haven't updated in a while, but we were able to post quite a few things on there that people might find interesting and useful. So I know in the next little bit, we'll be posting more of the meeting summaries that we haven't been able to post as quickly as we'd like. And certainly our final report would go up on the task force website as well. Post task force, that's something that we're still trying to figure out. So we know we need to improve communication and awareness around pain. If I could look into a crystal ball and imagine the future, I know that's going to be a big part of the final report from the task force, and it's something that we as a government will have to figure out. We sort of have a preliminary plan in place to create more of a pain-related webpage on the Government of Canada site. So similar to other chronic conditions, where there's information and fact sheets and resources related to arthritis and diabetes and dementia and other sorts of health issues, we'd like to see something similar for pain and chronic pain. And we have ideas about how we could build out content related to that. And that could be a potential mechanism to further communicate and post different ideas. But apart from that, I think we'll have to consider it. And I mean, we know communication is important. We know we've built a pretty big distribution list over the last 18 or 19 months, whatever it's been, and we can continue to use that distribution list to communicate federal actions. And of course, if anybody's interested in getting on that list, please send an email to our generic address so we can include you, and we'll be communicating as things get developed.
Great. So those are all of the questions that I can see in the chat. Eileen, I see your other question about triplicate prescriptions, and hopefully we can solve that with this information that we're going to send out. But if there are any other questions, we're happy to take them. We're happy to take them after this webinar through the email. So maybe Jen, I'll turn it back over to you.
Sure. Yeah. Well, I just want to say thanks again to the three of you. That was really informative today, and thanks for taking the time. And thanks to everyone who came. We really appreciate your questions and your attendance, and we hope to see you very soon, I guess, in the new year. And until then, wishing everyone a great December. Thanks, everyone. Bye-bye.
Thank you.
Bye, everybody. Thank you for attending.